Got it. And then, I'm going to invite our other panelists to begin asking a few questions, and hopefully we can maybe get towards the diagnosis, and then we'll do some of our facilitated panel discussions after that. And so I'll invite first for Dr. Prashant Singh if he has any questions for Dr. Sanjeev about this particular case and what the next step should be.
Shawik, I think Dr. Prashant is having difficulty. You may proceed to the next panelist.
Oh, Dr. Yogita, are you available to begin querying Dr. Sanjeev? And if not, we may move to our US experts. Dr. Manabi, what about you? Do you have any questions for Dr. Sanjeev that can help shed a little bit of light to this case?
Yeah, so this is a really interesting case. I was wondering, was anybody else in the family ill, or had they been ill in the last month?
There is no history as such. There are no history suggestive of similar complaint in the family.
And with that, Dr. Sanjeev, you mentioned that nobody had any upper respiratory symptoms, but any of the classic loss of smell, taste, just sort of mild fatigue, anything like that?
Nothing. There is no history suggestive of the symptomatology as prescribed by CDC.
Dr. Manabi, I may have interrupted you as you were asking another question.
No. So to be honest with you, even though it's the time of COVID, one must always think about not COVID. I know that this is a COVID seminar, but to be honest with you, at this point, I'm not sure that COVID would have been at the top of my differential. I think there are many reasons for this patient to have complete heart block. It would actually rule out the usual suspects, as we say in America. So this is not a classical case by any means. So I just wanted to make that sort of clear. And in terms of the testing that was actually done to rule out COVID, since it is the time of COVID, what actually was done?
Yeah, actually, after this, shall I proceed in just?
Yeah, Dr. Sanjeev, please go ahead. Please go ahead. Proceed.
Yeah.
Excuse me.
So what happened after this? At this moment, what we did actually is we are following up. We are doing screening because there's a peak of COVID and they're coming from, the positivity rate had gone up as well. And by the time the cardiologist actually came, so he was coming, it was taking some time. We did a routine screening ultrasound, of all this COVID patient for looking at any lung signs of COVID, lung signs. So like, before we got X-ray, it will take some time to get the X-ray done. So we did a lung ultrasound. We found few, bilateral, peripheral B profile with some shredding at, lung zone 4, lung zone 3 and 4, bilaterally, but patient was not symptomatic for it. Patient did not have any respiratory symptom, neither upper or lower respiratory symptoms, or the patient saturation was normal. He was asymptomatic on that, but patient had some positive lung ultrasound finding, at some shreds and few B profile on bilateral volume. This actually increased our suspicion, and we had to do a goal-directed echo. Echo was fine. Echo did not have any regional wall motion abnormality, no global hypokinesia. So to rule out other condition, maybe a condition, to see because the patient had complete heart block. So when we got the focus, and got some shredding, then we had some high degree of suspicion that are we dealing with, are we dealing at that context, peak of this time, are we dealing with COVID? Before that, we never had any idea this can be COVID because the presentation did not have, was not related to COVID. It was purely we are managing as if we are managing a acute coronary syndrome as per the ACLS guidelines. So we're managing, he was managed as per ACLC guidelines. And then we actually got the testing done. And after that we sent, because cardiologists also, they want to, before shifting to the cardiac echo room, to their department, because they had to put a, temporary and permanent, temporary pacemaker, they would require a testing as well. So they're not taking the patient just like that, even though the director had said that, that you have to do acute care procedures, you need, so without testing. So they wanted a testing. That's why we did a rapid antigen test kit. And the rapid antigen test kit actually came out to be positive. Then this patient was actually shifted to what COVID care center. After the TPI was, they actually registered on doing TPI because patient was hemodynamically not that unstable. The BP was 92/60. Patient was conscious oriented. And that's why they did not immediately thought of, putting a TPI. They said, we'll just hold on. And then the patient was actually shifted to the COVID care center at our trauma center, James Trauma Center. And the patient was followed up then. So this patient actually, then on day 6, the day 6, she developed junctional rhythm, from complete heart block to junctional rhythm. And day 14, the patient's, the ECG actually became sinus rhythm on day 14. So in the meantime, so this was the journey of the, patient. And this patient was managed because this patient was managed, conservatively and without any interventions, without any big intervention.
And Dr. Sanjeev, so if I'm hearing it right, and any of the experts can weigh in as well, it sounds like this was relatively asymptomatic from COVID, although you did find the B lines, but it was felt that the cardiac manifestations were different. And so, if we were to classify this would be sort of an asymptomatic positive. And I think that leads us to maybe some of the questions that we can address directly to our panelists. And Dr. Manabe, I'm curious as to your thoughts, but as you said, I would not normally, if someone came to my unit with these symptoms, and we didn't have any sort of universal screening policy, I would not have thought that they would need to be screened. Now, with the prevalence of 20% positivity in the local area, it's possible that the hospital would want to screen somebody. But Dr. Manabe, this is for you really. So what are your thoughts on the utility of asymptomatic screening? And there's a lot of different levels you can think about it on, but I would say, what if it was just on the hospital level? Should the hospital be screening every patient that comes in asymptomatic for COVID? And if they are, what type of testing do you think would be appropriate?
So currently in the US, because we are not a resource limited setting, we do test every person that comes into the hospital, and that is largely to protect the healthcare workers. All healthcare workers wear the sort of universal COVID precautions with a face mask and also with a face shield. But I think that it does help people to feel more comfortable in their working environment if we can segregate early on. As you know, antigen testing is slightly less sensitive than molecular testing, but it's much more available. I think that asymptomatic COVID is the superpower of COVID, where people don't realize that they're infected so that they can transmit to others. And it's particularly relevant in people's households, where they often do not mask and do not practice social distancing because, of course, they're at home and they want to feel safe in their own home. So I agree. As I said, it was sort of an atypical case for COVID, but one where if the ambient positivity, meaning you're having a big wave, you would have a higher pretest probability in such a case because you have so much COVID circulating. And so testing at that time, I think, to know everybody's status makes a lot of sense. When COVID positivity rates fall below 5%, I think that each jurisdiction has to make a decision where resources and amount of resources may also play into that decision. You should know that when ambient rates are low and people are just asymptomatic and kind of want to know their status, you increase the likelihood of having a false positive, particularly with antigen tests. So I think that it was a good thing to do when you have such a high ambient rate of COVID. As rates fall, though, you must be careful, because if it's positive, you may tell people they have COVID. In fact, when they're just false positive, they may need molecular test confirmation. So how much COVID is around and your pre-test suspicion for COVID can very much change the likelihood of the sort of the performance of the test itself. And many people don't think about that. So if your pre-test probability is high, you're really worried about COVID because they're symptomatic, they've been exposed to a COVID-19 patient, or there's a lot of circulating COVID, antigen tests can be very good in that particular time.
9 o'clock.
Great. Yes, it is 9 o'clock. Dr. Ravi, thank you for that answer. I think that makes a lot of sense. It is, I think we all have a tendency to want to simplify testing and our diagnostics, and for things to be very binary, that if positive, yes, you have, but that's not always the case. And it does make interpretation pretty challenging. One thing that's been coming up, recently and has been going on quite a bit, but more so in the news is, there's a lot of talk of variants, right? So not just amongst healthcare workers, but our patients are talking about variants. They're asking me about variants. What's the next variant going to be? Dr. Singh, this question is for you, Dr. Prashant Singh. I was going to ask you, do the variants have any effect on our diagnostic strategy? And as new variants are coming up, does it alter the testing characteristics? And do we need to be cognizant of that as we're choosing tests and new variants are coming up?
Hi, Dr. Chatterjee and everyone. This is Prashant here. So variants. There was a study done by the FDA, and they released a document back in January, where they claim that so RT-PCR, usually all of the RT-PCR tests, usually a majority test for at least 2 gene targets of the SARS-CoV-2 virus. So even if it's a very sensitive test, yes, but they've noticed that it is possible that variation or mutation in the virus may cause. PCR still remains very sensitive. Even if 1 gene is not picked up, since the test picks up 2 or 3, you will a positive person will turn positive. The problem may occur with antigen tests. So they may have some false negative results, although that is not documented to date. So you can't really say with certainty, but variants can theoretically can cause some change, but RT-PCR will not have any issue.
Great, thanks, Dr. Singh, for that. And then Dr. Oliver, I think this is somewhat in your wheelhouse, but I was going to see if you had any thoughts on the same question.
So that is something which there is a lot of work being done on, and this is more in terms of monitoring. But if we get to a point where there are assays which are not detecting particular variants, that's going to be very newsworthy. That's sort of beyond variants of concern, right? Those are variants of high consequence, and you will hear about that at pretty much the minute they're detected. I mean, this publication rate right now for COVID is like so ridiculously high. I think the next step is that they're going to monitor what we type, and so that you get the news directly as we're thinking it. But sorry, that was a bad joke. Anyway, yes, so those would be variants of high concern, and we have not seen those yet.
Right, and Dr. Leonard, to elaborate on your joke for everybody, I think it's, there is, I think, concerns that things and information are released in very small and early packets without depth and context, which can be challenging for us as physicians and providers, and I'd say even more confusing for the lay population to sort of figure out what to do, which there's a lot of confusion about what to do, which is one of the reasons we're having this session and getting your guys' expertise. Dr. Yogita, I had a question for you specifically about the immunocompromised population, and if there is something unique and or different we should be considering in testing for the severely immunocompromised patients.
Sure. So I would give this question to Dr. Lakshmi. I will be focusing on the point of care challenges, operational challenges, please. Thanks.
Oh,
Thanks,
of course.
Doctor.
Yeah, sure. Dr. Lakshmi.
Yeah, so with respect to the immunocompromised patients, coming to the part of the testing, there is no different test which we do specially for them. It's only the RT-PCR still exists. So for the pediatric also, we go in for the RT-PCR test. So for specifically for these compromised patients, we do not have any different test that's coming up here.
Thanks, Dr. Lakshmi. And Dr. Yogita, do you want to tell us what you were going to say about the point of care testing, and specifically, you're talking about home care tests? I know that they were recently approved in India, but I'm not sure what the uptake is in people who are using home kits.
The home test.
So, sure. So Souvik, I wanted to focus on one is that where all we get stuck in point of care testing, the home testing, and testing at a primary care community level, because now point of care is the next answer for this. Besides developing the capacities at district level and medical college level, testing at a primary healthcare center using a TrueNat machine or other point of care RT-PCR or rapid antigen test. So because from my experience, I would really like to add value to this. So
Please do.
Thank you. Thanks. So one is that in the house-to-house surveillance, ASHA worker and Anganwadi worker does the screening of symptoms. There is no electronic entry till the primary health center level. So whatever data they enter is entered at the primary health center in the ICMR portal. So which creates a lot of confusion when there is a pandemic. So there has been a lot of chaos in terms of early identification and isolation of patients who are suspects. Two, that a multi-purpose worker would conduct a rapid antigen test in the community. So now the rapid antigen test, again, the report would be entered at, he'll have to travel to the primary health center and enter the reports, etc. So that has also, created confusions and in data, because data is something which is very, very important for us. And surveillance is the key to the control of this pandemic. So what FIND has come up with, and even at a primary health center or community health center, any center, there is no data capture, electronic data, digital solution for capturing data of a rapid antigen test. So what FIND has come up with is a solution for capturing data of a RDT, where it enters the SRF ID, a picture and a result, and it automatically goes into the ICMR portal. And the ICMR from the ICMR portal, it gets automatically pushed to the patient's phone as a report. So this can actually change the surveillance methodology using RDT, because currently it is very scattered and manual. To that, when we consider using a point of care PCR kind of test or even a rapid antigen test, we need to consider that what are the available resources with us, because currently a primary health center lab technician does not even know how to do hemoglobin. So no matter how easy it is to do a point of care PCR, but at the end of the day, it is a PCR. It needs very critical eye, it needs attention, it needs expertise. If less, it is written in the manual that if the fan is on and you're pipetting, the result will be erroneous. For example, another example is that if you don't wait for 2 hours, that is not even written in the manual, that if you don't wait for 2 hours in the VTM and then start testing, the result will not come out the way it should. It will be erroneous. So all these things have to be factored in, that where is my capacity of the technician? Am I ready to install TrueNats in every primary health center? Are my technicians trained? Because currently the trainings for TrueNat are not really in place. So are we working equally on capacity building of our country, that we have easy to use training modules, videos, etc. for our lab technicians, because that is the main workforce. Do we have training materials ready to use for our microbiologists who can train? Do we have a training structure? Do we have supply of reagents, which is reaching in a pandemic? Will it reach all the reagents? Will they reach even till the district level? Forget about the primary health center. So is there supply of electricity? Is the battery, if it is finished, how soon it is replaceable? Because equipment maintenance is something which is it is a separate program in Government of India, which is called BMMP, Biomedical Maintenance Equipment Maintenance Program. So, but even after 6 years of rollout of this program, states are still suffering with equipment downtime and many months of unavailability of equipment because of not being able to repair or not even able to get spare parts. So it has to be COVID. It has to be looked at in a very, very holistic public health manner also, besides the clinical aspect. I have a lot to speak on this, but I will stop here because I understand there's paucity of time. Thank you so much.
Thank you, Dr. Yogita. I think you nicely outlined some of the things that we probably take for granted, certainly in the US when it comes to testing, and all of the things that go into play, from ordering the test is just the first step. And then there is so much more that has to be done. There's so many quality assurances that have to take place. So thank you for sharing that perspective. Dr. Manabi, the next question I have is for you, and it's about what we should be doing as the prevalence of COVID, thankfully, is dropping a little bit, certainly in the US, also from its peak in India as well. And we're heading into the fall and winter here, which is a season of seasonal influenza and other viruses. And what do we advise our patients who are having mild upper respiratory symptoms, maybe in a state where the prevalence of COVID is not very high? And should we be testing all of those people, and how aggressively? Do we need to save our resources? Or what should our approach be?
So obviously I'm not a policymaker, so I can't tell you what the resources are. If this were an ideal world, I would tell people that they should know their status. And they should know their status because with COVID, if you're positive, you may want to make sure that you have a way to monitor your symptoms and to see what your oxygenation is so that you can get to hospital before things are dire. We know that people that monitor their pulse oximetry and go to hospital earlier do better. And there definitely is something that we call happy hypoxia, where people actually are quite hypoxic, but they live at home and they feel fine. And then they crash. And if they crash before they come, we know that they don't do as well. So I think you should know your status. I also think that oral drugs are coming. So there is this new Merck drug, molnupiravir. It's very difficult to say, but it is an oral medication that could be taken. So if you find out early in disease, then you could take potentially molnupiravir. And I read in a paper today from the New York Times that in fact, there are going to be places in India and in Africa where they will be producing this drug. And this does prevent hospitalization. So I think while we're waiting for people to get vaccinated, it would be nice to have options. There are also going to be multiplex antigen tests that will also tell you about flu. So flu is another thing which could be treated. It's also transmissible, and you may want to know about it. And we may see more flu this year than we saw last year because, of course, people are not masking as much. So I'm not sure I answered your question so directly, but I think that knowing your status, if you have those resources, is always good. And in symptomatic patients, the sensitivity and specificity of the antigen tests is pretty high. And so I think that because they're generally relatively inexpensive, it would be better to know than to not know.
Yeah, no, Dr. Manabi, thanks. And partially that was a selfish question, right? Because this is what I'm dealing with now. But I think a lot of our providers are, and I think as everybody has their roles to play, right? And I think as providers, most of the people on this call, it's important to have that sense that it's probably worth testing, particularly because you're going to change behavior and or your action thereafter, given the technology and with where we are now. So it is 9:13.